So here we are, we're on week 8. Week 8 is a hard week because you have quite a bit of, homework due. If you have not done anything with your pediatric assessment project, it's a lot of work to do. Remember, I need to know what you're going to do it on before you can do it. So send me, this is the diagnosis I want to do. Rarely I will say, I've already have 3 or 4 of those. Give me something else. Okay. I think I've done it once in 2 semesters, whereas I made a student change, but just let me know. Okay. And if any of you know me, I'm actually really quick answering. And if I'm answering quick enough, you've got my cell phone. Text me. All right. It's as easy as that. I can get you approved if that's when you can do your project. Remember, there is a case study. It's the pediatric assessment assignment exam. Remember, it's the first grade that you receive. You can't do it over and over again, okay? It's one attempt. And then also with week 8, there are 50 NCLEX questions. Make sure you do what is appropriate for this week. And you'll see it in the modules, what the areas are that you need to cover. Next week, we're going to start reviews again, and week 10 is also going to be exam. Anybody who needs to get with me before exam 3, please make an appointment. I'd love to meet with you one-to-one. First, watch a review, look at the study guide, come to me with some base knowledge, and then I can sit there and quiz you about concepts and try to help you get through that grade 3, exam 3. I know most of you are like, oh my, and then there's this HESI, am I going to make it? Well, if you do what I tell you for the HESI, you'll be over 900 as your HESI score. If you do what I tell you. I've got great Kahoots and I've got a great PowerPoint that I put out called HESI Q&A. And if you look at that, you study that, you're going to be above 900. I've had quite a few 99.99 students with the exam grades in the low 80s, just barely getting there, getting 99.99 because they really put in the effort. So anybody can get it. Don't think it's just because you have to be smart. All right. Yeah, I make it very easy for you, but you have to put the work in. All right. Anyway, any questions? And here we're going to go for the week. GIGU is a crazy week. It is a lot of information, and you're going to see there's a lot of things that you have never heard of before, especially when it comes to GI. And there are a couple in the GU that you're like, I didn't know those things. And some, you've heard because MedSurg has been going through a lot of this stuff too. So GU, urinary problems, the biggest one in kids is what? Let me make sure that I'm on record. That's the one thing I want to make sure. Yes, I am. All right. Sorry. So remember children. Children are the biggest thing that can happen with the GU problem is just simple old urinary tract infection. Why is the reason? Well, girls have this short, wide open urethra, sitting in bathtubs, not wiping properly, potty training, all of those stuff causes a lot of urinary tract infections. Plus, they hold it, right? Um, Another thing is uncircumcised boys, and this is the young children, the infants. A lot of parents are afraid to pull down the foreskin and clean. And, it's something that it can hold up a lot of gunk inside of there. So, and can create infections. And the other thing about urinary tract infections and as nurses that we need to tell our parents and kids, they need to finish all the antibiotics. We think that after the symptoms are gone away, they're fine. But remember, it takes the whole dose to get rid of it. And remember, this is your kidneys we're talking about. And children don't have huge defenses. Our immunity against stuff builds as we get older. So we don't want that child to have to do 2 or 3 different courses of antibiotics because they never finish it, right? Let's get it right the first time. So how would you know a kid has a UTI? Well, that incontinent child who has, been potty trained. you're smelling that urine, that's a no-brainer. And then that frequency, urgency. And, you'll all see girls and boys, just rubbing themselves down there like it hurts. There's raw, there's something going on. They're wiggling back and forth a lot. Well, those are things that you would see. So, what do we teach our parents? Well, to look for those things, those urgency, those accidents, etc. I mean, one accident doesn't make a UTI, but when it smells bad, yes, that's your UTI. Remember, it's all about potty training, it's about wiping front to back. And in adolescent girls, we would say that yes, mommies think that their little girls are not having sex, but we know that happens. I mean, I'm a girl, I understand that. And if you see an adolescent coming in for a lot of UTIs, and if they are sexually active and will tell them to urinate as soon as possible after intercourse. That decreases the incidence of UTI in adolescent girls. So we need to find out what that bacteria is. It depends on the kid. How big are they? Well, young infants, we're going to do a catheterized specimen, period, end of subject. No, we're not going to bag them. No, that catheter doesn't diverginate them like some parents and some fathers think. Oh, it hurts. No, it's just they don't like to be held down, literally, because the lubrication comfortable for a second and then it's gone. But you got an accurate specimen the first time. That means we can accurately treat whatever bacteria is creating the infection the first time. Because infants don't have that immune system, right? So, especially the young ones, we're going to do that. Now, what about the premature itsy bitsies? Well, there is no little tube, no catheter small enough. These children, premature, I would say less than a, a kilogram, less than 1,000 milligrams. These children, we're going to be doing what we call a suprapubic aspiration. And what they do is right above the suprapubic bone, sterile gloves, sterile needles, sterile syringe, clean off the area right above that, and they directly stick a needle down into the bladder and they take a specimen. That's how that is done. But you can understand how important it is to get a proper specimen and a proper specimen for culture, right? We want to make sure that it's done correctly. There's other things we can do. We can look at the kidneys. We can do this, put a catheter in and wash out stuff, get stuff. Um, we can do an ultrasound. Is it reflux going on? Are the valves in the vesicle or the bladder that goes to the ureters, are they open? Are they constricted? Is there a stricture in the ureters? Is a kidney with hydronephrosis? All of these things can create scenarios that can tell you something's wrong with the kidneys, which is evidenced by that urinary tract infection. Now, phimosis. This is when you try to pull down that foreskin to clean it out and you can't. It's so tight. It's one of those things that we need to pull it down. We need to clean out that, with that schmegma, that's that white cheese-like substance between the foreskin and the penis. We need to clean it because it's like a petri dish to grow bacteria in there, and you can't. My grandson, I had to do a circumcision on him at 30 days old because I couldn't even pull it down, and I knew what the incidence of getting infections were, and then I let my mother or his mother do what she felt. She says, "No, I think you're right. We need to do it." Now, ballantitis is when you pull down that foreskin and it sits there and it swells up. So either or, they're both an emergency. They both need to be looked at in order to correct. Now, phimosis could be a circumcision or might need just, more manipulation to it because it's just tight, tight. It could be a steroid cream, depending. Now, hydrocele. This is water in the testicles. A lot of times you're going to see children like this all of a sudden are incontinent or have pain in their testicles. The older kids will tell you. Young children, they don't really say anything, and it usually just goes away. All right. Now, cryptorchidism. The testicles are born up into the abdominal cavity. They're not in the scrotal sac. It could be one, it could be both. And the thing is, we want to get it down as soon as we can. Like they usually say the first year or as close to, that is possible because the heat of the abdominal cavity kills the eggs, or kills the sperm up in there. So they now are going to become that they're not going to be fertile. They're not going to be able to have children. So we try to get it down. Now, one of the things about cryptorchidism and looking for it, make sure that room isn't a cold room that you have that baby in. Testicles contract with cold and they tend to get bigger when it's warm. So when it's bigger, it's warm, it's relaxed, more ability to check for testicles to see if they're there, okay? Especially if one's a little bit up. Now, there's something called hypospadias and epispadias. Now, hypospadias is when usually the urethra comes out of the end of the penis, right? Well, in this case, it's somewhere on the bottom. Hypo, on the bottom, okay? It's on the dorsal, through the door, right through there. Something is wrong. It doesn't come out to here. Now, what is the thing about this? Well, these children, you cannot circumcise. That's the big thing. We need that skin to do a plastic closure. If you can see that incision line on that penis of the picture, they filleted that penis open, created a cavity to put the urethra to go to the end, then use the foreskin tissue to close it up. Post-operatively, they put in a tube or a catheter. Actually, what I've seen is, ever seen the straight calves used for females? It's like that clear plastic tube. You might have seen them in SimLab. That's the tube they leave in there for up to 2 weeks. And we don't touch it. We keep it inside the diaper so we don't get urine everywhere. And that creates the lumen of that urethra, okay? So post-operatively, that is the treatment. Pre-operatively, well, the urine's going to squirt out the wrong way, and we do not circumcise. Now, exstrophy of the bladder, or an epispadias. Well, epispadias is when it's on the top. We have either on the top or we have it on the bottom, where the penis doesn't go where it should. And you wouldn't be surprised how many different anatomies, that you can see ever working in the newborn intensive care unit. Now, epispadias goes the same way as a hypospadias, okay? But it's on the top of the incision, not on the bottom, all right? Bladder exstrophy is when the bladder is born on the outside of the lower abdomen. That means it didn't get closed inside. Now, our biggest concern with this bladder exstrophy is to keep that tissue infection free and keep it free from irritation. And then, they're still going to urinate the normal way. Their bladder's just on top. And then usually within very short time, they try to get that bladder back inside the body. There's another thing that happens with the stomach on the outside, that same thing, that we keep it sterile and we keep it free from infection, and that we're going to put it back inside the body soon. So surgical treatment for these things, again, we want to put it inside. We want to get that bladder doing right. We want to make sure that we haven't hurt that bladder. And again, it's preventing problems for that child in the long run. There's the epispadias, that's the hydrospadias, hypospadias there, the dorsal space. I mean, you can see what intensive surgery it's done here. So post-operatively, of course, is always measuring urine output, watching for infections, and pain management, right? Remember, these children, make sure the toys and whatnot, activity they do post-operatively, you're protecting them. You wouldn't have them throwing hard balls at each other. It could hit them in their groin, right? They wouldn't be on a riding horse or a bicycle. It could hurt that penis and that incision line. So again, think about safety post-procedure. Now, sometimes you got to do what we call a renal biopsy. Something's happening in the kidneys, infections going on, you're concerned, or maybe you see a growth or something, and it's appropriate to do a biopsy. Well, it's sort of similar to your cardiac cath. So it's the same sort of pre-op before. Infants, again, you're not going to have them as long without eating or drinking because they need their glucose. They burn it up too quick. But we're going to be doing a biopsy of the kidney. They usually with ultrasound on infants, look for it. Sometimes they have to cut open a little incision in infants, all right? Postoperatively, what are we concerned about? Well, even if we didn't have to cut it open and look for the kidney, we have punctured the skin into that kidney. Let's look for any drainage, bleeding in the abdominal cavity, oozing of urine through the dressing. These children are on bed rest for 24 hours, just like cardiac cath, pressure dressing, just like cardiac cath, and taking vital signs, okay? But we're going to be monitoring the abdominal cavity for tenderness, and we're going to be monitoring urine output. Now, obstructive uropathy. Remember, bladder is called a vesicle. So vesicle ureter, ureter vesicle has to do with the ureters and the bladder, the vesicle, okay? There could be a kink anywhere. One side, both sides, double kinks, small kidney, big kidney, all of these things can occur in children. And as I said, urinary tract infections are usually, we start looking for this sort of stuff. Now, one of the conditions that we see is something called nephrotic syndrome. And I'm going to tell you twice. This has nothing to do with renal failure. Nephrotic syndrome is not renal failure. Your kidneys are working, but they're saying, ooh, protein, yuck, and get rid of it. And you see protein like crazy in the urine. So what do you have? Proteinuria, protein in the urine. Protein is also in the blood. Albumin is called protein. So hypoalbuminemia. So now you got to be careful with drugs because you have low albumin level because there's nowhere for the drugs to hop onto. It's all free drugs all over in the blood system, and that increases blood levels, okay? Very careful. Another thing, no protein inside the blood vessels. You're going to see that fluid inside is going to try to plasma. It's going to go interstitially. So then generalized edema. So these are those key things we see. Blood, I mean, you're going to see urine looking foamy, and that's why I put the picture of that there for you. Now, nursing. What are we going to see? What is our concerns? Well, these children are immunosuppressed, okay? Just like sickle cell, rheumatoid arthritis, diabetes, doesn't matter. It's another immunosuppressive disease. So we're going to be careful about risk of infection. Number one, always that. Now, these children are swollen all over. Even their mouth gets swollen. They're biting on it. It hurts. They lose their appetite because of that. Now, how are we going to manage all of this fluid? Anything that has to do with fluid, nursing function, intake, output, daily weights. I don't care what age, from infant to adults. Anything that has to do with fluid balance, retaining, losing it, intake, output, daily weights, okay? It really monitors what's going on with that child. So these children, salt restriction, fluid restriction, and then let the family understand why these things can hurt the child so that siblings can be a little bit nicer to their brothers and sisters. Because I had 6 brothers, they were mean. So if I couldn't have something, I know they were going to tell me about it. So if they understood the severity, I think their brothers and sisters would be a little bit more sort of nicer, hopefully, because I know how mean they can. So nephrotic syndrome, supportive care. We're going to try to reduce the excretion of urinary protein. We give steroids to these children. It's the treatment for it. They prevent infections. Remember, steroids mask the sign of infections. And again, you have to minimize any complications due to sepsis. And then look at that fluid balance. What's their priority? Intake, output, daily weights. All right. Acute glomerulonephritis. Well, we've heard about rheumatic fever, right? This is the other disease caused by Group B strep. It's another strep infection. So if you don't get rheumatic fever and you don't have heart valve damage, it can attack your kidneys. So strep is something that we need to make sure they take all their doses of medicine, right? You can see why now. So what would we see with acute glomerulonephritis? The kidneys are attacked by the strep. They stop urinating, oliguria. Fluid's got to go somewhere. I'm getting edematous. With all that edema, kidney problems, hypertension, and then periorbital edema. Big thing is that periorbital. They're going to get headaches. Probably they're hypertensive, right? Their blood is going to have urine in it, and you're going to have protein in there also. So those are the signs and symptoms of it. Now, what are we going to do? Well, we're going to treat the strep. Absolutely, we're going to treat it, and they're going to treat the symptoms of these children of this. Usually, it's just an acute stage. We can take care of it. It goes away, and it's fine. If it goes on over a year of treating it, it can become a chronic glomerulonephritis. So again, how you manage any problem, kidneys. It's all about fluid, right? Daily weights, intake, output. This one we might do some abdominal girth measurements because it's the kidneys inside. And again, nutrition, fluid restriction, low sodium diet, and be careful. Again, susceptibility to infections. Very similar with both of those diseases. Now, Wilms tumor, we've talked about it before. Again, it's the kidney, so I have to mention again, nephroblastoma. It is more common in boys than it is in girls, and it's about that 3-year-old stage. And remember, this one is all about do not touch that abdomen. Don't palpate it. It's very fragile, this tumor, and it could metastasize in the peritoneal cavity. And that's what we don't do. We don't even do a biopsy on these. We're like, you find a tumor on a kidney, we're assuming what it is. We're going to do maybe chemo, maybe radiation, maybe both. And then we're going to go in and remove it. Now, acute or chronic renal failure. I was surprised how many children had chronic renal failure. I was doing clinicals, wasn't a unit that I worked on, but I was doing clinicals for a college, and I was on the GU floor, and it was amazing. The kidney dialysis unit, it was always full with kids getting dialysis, and I was, how does this happen? Well, acute renal failure, the one big thing that can cause it in children is severe dehydration. You think dehydration, you think adults, you don't think kidney failure. In children, severe dehydration can cause acute renal failure. And we know it's all of a sudden you just don't start urinating. And of course, all of those um, things build up in your body. Sometimes we can do a dialysis and get it going, or sometimes it clears up itself. It all depends on the kid. Now, chronic renal failure. What they describe, the definition is greater than 50% of the renal capacity is destroyed. That means the kidneys cannot take care of what it really needs to do normally. And it's going to get worse as time progresses. It's also called uremia. Now, what causes chronic renal failure? Well, look at that. Some of those strictures, those congenital renal urinary tract malformations, those refluxes. I heard hereditary, chronic pyelonephritis, glomerulonephritis, and then of course, look at lupus, and lupus can attack kidneys, right? Or what about a severe allergic reaction, anaphylactoid purpura? could attack the kidney. So there are things that can cause it. What is our goal with renal failure? Well, we want to promote the best function that we can. Our goal is to look at the fluid balance, electrolytes, make sure they're okay. Remember that erythropoietin is all about the kidneys. It's not there. Hemoglobin's not being formed. So maybe giving some erythropoietin injections to help stimulate the body make its own can help a little bit. And with chronic renal failure, they're always in a dialysis somewhere, 3, 4, 5 days a week, depending on the severity of the child. Again, try to keep them as normal as they possibly can. I know I walked into the dialysis unit and they had 3 kids in there and they had 2 nurses and they were sitting there playing guitars and singing together. And they had, made a trio, 3 of them in there, the nurse and 2 patients. So they try to make them as fun as possible. Now, young infants are too small for dialysis, hemodialysis. What happens is they can't pull out the blood, filter it, and push it back in. That pushing back in of blood, the flow is so high, it's going to rupture vessels in their brain. They can't tolerate it. So, and it's even something they're doing more frequently with adults, and that is peritoneal dialysis. This is a great picture. You see that plastic tube that sort of bends down? That is the peritoneal dialysis tube, the tube that goes into the peritoneum. And what they do is they're going to put fluids into that abdominal cavity, warmed fluids, and that warmed fluids will, whatever the amount the doctor says, 50 mLs, 100 mLs, 200 mLs, depending on the size of the child, and then it will sit there inside and soak up through osmosis those debris, those things that the kidneys would normally filter. And then we drain the fluid for a certain amount of time. So an instill, a still, and a drain is one cycle. Usually at night, they do this on these infants so they can sleep. And usually it's 8 to 10 cycles in one night that they'll do. So it works well for the child and for the parent. It's done at night. There's a machine that does it. And usually either the parents taught or somebody comes in and does it for them. So this is what this is all about. What is our concerns? What do we need to watch out for? Well, many times we as nurses, we don't touch this at all. I actually had the ability to become peritoneal dialysis certified. So I got to watch it as soon as I saw what this was. They were offering a course. So what they do is it's just like a dialysis machine, but it's just liquid in, put it in and dump it out, but it warms it and it's a certain amount. It's setting up this machine with super sterile technique. The biggest complication is getting that peritoneal cavity infected. It's the only kidney you have. Once it's infected, there's no kidney. So if any change in the color of the fluid coming out, or redness, abdominal tenderness, or debris coming out in that tube that's not normal, call the doctor immediately. This child is probably infected. Let's start antibiotics. But your priority, tell the doctor, let them know, get the order, get the antibiotic. And this usually, these are done at home. Even actually, I had a best friend who was a nurse actually with me, who ended up peritoneal dialysis at home before she had to go to hemodialysis. So, which best describes acute familiar nephritis? What is acute familiar nephritis? The kidneys, they're infected. Why?
B.
It is. It's after a strep infection. Remember, it's just like rheumatic fever. All right, GI dysfunction. GI, mouth to anus, and everything in between. So that's where we absorb all of our vitamins and our minerals. And there's things that causes delays in those absorption, cancer, HIV, sickle cell, cystic fibrosis, and low birth weights. All of those can affect it. Now, celiac disease. Celiac disease is a gluten sensitive enteropathy, which means child who eats any sort of gluten product, wheat, rye, barley, oat. They eat any of that, their stomach and small intestines just absolutely goes crazy. It causes severe, severe pain. And the child remembers they're not going to eat that again. Something called steatorrhea occurs. It has to do with fat absorption. So these children don't absorb fat. It's the highest calorie content of any food. So these children, high carbohydrates, high protein, and low fat. If you start giving them fat, they'll have abdominal distension and a lot of gassy pain, all right? What they say is a good thing is rice is a good alternative food. I mean, just think about a toddler. No wheat, rye, barley, or oats. That means no macaroni and cheese, no chicken nuggets with breading on it. And I think many of you know toddlers, that's their main food group, those two right there. So what would you feed them? Got to think about something that's gluten free. You know, today we're lucky. Supermarkets even have it listed gluten free, gluten free. I mean, 20, 30 years ago, it wasn't there. It's actually easier than it is today. You know, food allergies, we talked about the infants and how we start to feed them very slowly. We're concerned about food allergies. Um, Now, what if they have a lactose intolerant? That means they can't have milk. Are they getting vitamin D? Are they getting calcium? These are things that we have to think of with food allergies because they can't eat it, the intolerance or the allergy. If it has a food, something that we need, in order to grow, we need to replace it in another way. Now, GI dysfunction causes many things. Growth failure, it's part of spitting up, nausea, vomiting, diarrhea, constipation. Like I said, with celiac disease, abdominal pain, GI problems. What if it's, an obstructed bile duct? Now that's, again, GI, it's off the common bile duct. Um, that is, and the liver is shut off. Well, jaundiced. And then what about simple? They don't know how to eat and swallow. There are some diagnoses, the George syndrome, Pierre Robin, both of them, dysphagia, dysfunctional swallowing is part of their syndrome. And then just what about fever? What does fever do? It burns up fluids like crazy, can cause dehydration. So dehydration caused by many different things. I always say with kids, number one is always that insensible fluid loss, fever, sweating. What if they're urinating a lot? What if vomiting, diarrhea, diabetes with ketoacidosis, burns a lot of fluids? Remember, dehydration can cause renal failure in these children. So we really need to address it quickly. Now, I chose these two pictures because I think they absolutely tell you what an infant looks like when they're dehydrated. That one on top, sunken fontanelle, the one on bottom also. Look at the color of that child. It's pale. Look at the color of the ears, pale. I mean, even the nose. I mean, you can see that kid looks bad. So, what are the concepts dealing with dehydration? What do you see? Well, the body has no fluids, elevated heart rate, trying to keep up with the fluid, that's not there. Blood pressure is lower because you can't keep up with it. Then they pull all the way, blood away from the extremities. So capillary refill becomes even more prolonged. There's going to be a decrease in urinary output. When you see an infant cry with no tears, it just breaks your heart. You see that depressed fontanelle, they're crying, and they're crying. There's no tears. That's a big one. And then what about skin denting? So you suspect your child that has dehydration. What are you going to do? Well, we're going to start an IV and do a lab pull, a basic profile, metabolic profile. We want to look at the sodium, the chloride, the potassium. We want to look at the glucose. Where are we? You know, remember, when we are giving this child, let's say it's a child with vomiting, and the kid looks this severe, not only we're going to give oral sometimes, but sometimes it just gives IV fluids. Remember, any bolus of IV fluids should never have in any dextrose, and it shouldn't have any potassium in it. Okay? No bolus with those fluids. Also, once you bolus that normal saline, whatever they want, whatever fluid until they feel the child's perking up, you don't add potassium until that child voids or until you have a potassium level from the lab. Of course, with vomiting, you're going to treat it, and there are antiemetics. Zofran, which, is your Zofran, or Densteron, which is Zofran. It's the most common of all the antiemetics now. So let's say you have a kid, looks like this child, admitted to the hospital. We weighed them as they walked in the door. They're about to go home 3 days later. How do you know all of this work? We gave them fluids, they're looking better, they're pinker, they're eating. What is that big telltale sign? It's fluid. They were lacking fluid. How do you measure it? Intake, output, and weights. You're going to see that weight on discharge is going to be higher than that weight on admission. Even on different scales, there'll be a noticeable difference. So measuring intake output, we can measure it by just, the urine, the stools, the vomit. I mean, I've never done sweating. It's never been that profuse, but if you put a chucks or a diaper underneath them and you know what that weighed beforehand, you can determine if it's that severe. But vital signs are going to tell it to you. Elevated heart rate, decreased blood pressure, that skin turgor, that mucous membranes, body weights, right? Fontanelles, I love fontanelles in the infants because it really tells me everything. Is it bulging too much or is it depressed and not enough? And it's depressed at rest, okay? They can cry and maybe it might come up to normal. I'm talking at rest. Now, diarrhea. There's all different reasons for it. Now, diarrhea, you can also lose a lot of fluid. But if a kid is just having diarrhea and no vomiting, we will feed this child and we'll give them fluids. We're going to be giving them an oral sort of rehydration electrolyte solution, Pedialyte for infants, Gatorade, Powderade, ice pops that are, Gatorade or whatever. Those things will help build them up quickly. And you're going to feed them because a diarrhea without food is still going to be liquid. There's nothing to make a stool. So you do feed them. And you know what the treatment is in the hospital always? Probiotics. Probiotics once a day until the stools are formed enough. And that's the end of it. Now, constipation. This is actually the only thing that a young child can control and manipulate. When they want attention, they can hold their stool. And I've seen it 10 days where they have not moved their bowels. When you do the x-ray, the whole descending, ascending transverse colon are full of stool and you could see it. And it could be because something's going on. Usually there's stress in there. So it's that psychosocial, that stress moment. It's not always due to a physiologic sort of reason. Usually it's stress. Now, constipation in the newborn period. Well, constipation can be due to hypothyroidism. I mentioned that when we were looking at endocrines last week. Now, it also can be some intestinal obstruction of some sort. And I'll go into what Hirschsprung's is in a second. but also cystic fibrosis causes constipation at birth. So you have a newborn infant, you don't know of anything they're supposed to have. You don't know, look at cystic fibrosis or thyroid, but they don't move their stool. They're going to check for three things: some intestinal obstruction, thyroid problems, or cystic fibrosis. So you're going to do a thyroid panel. They're going to do a sweat test, and they're going to do number one, just a simple x-ray of that abdomen, see what's going on. Okay. So three things: constipation, no stool, first 24 to 36 hours. Now, constipation usually happens more with bottle fed, formula fed than breastfed. It just seems that when you're feeding the breast, they have looser stools and more frequently. Now, formula-fed infants tend to be more constipated. Now, as they get older, there are things we can do. I put in here black beans because, of course, I live in South Florida, but it's a type of fiber. And also remember whole grains, oatmeal and barley and those cereals, those can also help with that fiber in order to help move the stool. Now, enterobiasis, pinworms. This is something that we see occasionally, and usually the child's complaining of itchy butt during the night, literally an itchy butt at night, and the parents are like, "Oh, go to sleep. What's your problem?" And maybe they'll say, "Well, you should have taken a shower," or "Here, let's wash you off," or "Let's go clean you." But it probably is these tiny little pinworms. They're due to children like to play outside in the dirt and they get it underneath their nails. So keep those nails short, and they everything in the mouth, fingers in the mouth, dirt in the mouth, pigs in the mouth, and they hatch inside. So the child's complaining of this anal itching, scratching. The thing is to go with a flashlight at night, the parent, with a piece of scotch tape, and put it over the anus and anal area and pull it up, and you're going to see a tiny little worm like that. It's at dark at night when they come out. That's why at night there's that itching. And then, of course, we bring it to the doctor and they can, give the medicines for it, and the whole family should be checked. Peptic ulcer disease, you're thinking, ulcers, kids? Little kids are warriors for some of them, and some of them do require things. I've never seen any surgical intervention with this. It's always that, it used to be Zantac, it's now Pepcid. Zantac was taken off the market, but Pepcid would be the first thing, or just changing diet with it. Hepatic disorders, we're talking about any sort of hepatitis. It can be due to many different reasons. The one thing that we always are concerned, any child with problems with their liver, it's always worried about fat, right? Fat's not digested here. That's the liver. The bile digests fat. So no liver again. So again, high protein, high carbohydrates, and that's going to prevent muscle wasting because fat is the highest calorie of all of the nutritional components. Biliary atresia, I've mentioned it earlier. This is when without no tube to connect the liver to the common bile duct. That means bile's going inside the body. What are you going to see? These children are going to have these pale stools, and you're going to see them starting to turn yellow, and they need surgical intervention in order to get that opened up. Hirschsprungs. This is the other thing in that no stool in the first 24 to 36 hours after birth. Now, you see that picture up to the top right? That is a big area where it's stretching out and stool is there, because you can see below it, there's no opening and it can't go out through the rectum. Okay. But you're like, well, maybe it should hurt. There's no nerves in that area, no peristalsis, no nerves. It stretches and stretches and stretches. And occasionally down that little tube comes a little ribbon of stool, but that's about maybe all you will see. It is called a congenital aganglionic without nerves megacolon. It is a useless piece of colon that we need to get rid of. Again, more in Down's children. Poor Down's children, hypothyroidism, leukemia, and now we're Hirschsprung's disease. A lot of things to look out for, these poor kids, right? So we do an x-ray, we do a biopsy, we find no nerves, and surgery needs to be done. We need to get rid of it. We need this child to start schooling. So there could be two types of surgeries. One is two-part. You make an ostomy, get rid of all that area, let it rest, and connect it later on. Many times they do what we call a pull-through procedure, as in we take out that piece of intestines and then inside connect the two ends. So never a colostomy is needed, okay? Now, post-op, you've done a lot of surgery right around the rectum. Do not do anything, no anything inside the rectum, so no rectal temperatures. And these children need their intestines rested, right? We've just, done major takeout pieces of intestines. We need it to rest for a little bit. So nothing to eat for 2 to 3 days. Acute appendicitis. How many of you had your appendix out? Nobody? These are the easiest kids to see in the ER. If they're walking in, they're bent over, their right hand is underneath their right lower quadrant, and they're limping on their right leg. And you could see, oh, that kid hurts. You're like, oh, that's an appendix. Now, after a while, it got very easy to see. McBurney point, right lower quadrant, guarding. You hit the bottom of their foot on the right side. They hurt. They can't bend it up. All of those things you would see. Do an ultrasound and we'll confirm it. Now, when we think a kid is an appendix, our first chore should be to tell the child not to eat or drink anything else. That kid's going to surgery pretty quick because we don't want it to burst inside, right? The first inside, we have peritonitis, and this is the worst case scenario of appendix. So, postoperatively, the appendix with all that gunk has gone inside the peritoneal cavity, and all of the insides are upset, they're inflamed, the intestines are angry. So, nothing to eat or drink, and there's an NG tube down to stop any gastric juices even from going down into the intestines. That's how angry it is down there. So we're going to give antibiotics priority, right? We're going to give fluids. They're not eating at all. Of course, we're pulling out, secretions from their NG tube and we're only giving fluids. So labs are very important. We're monitoring white cell counts. Remember, this is an infection. Are the antibiotics bringing it back down? Another good thing with this one is really good pain control. I mean, they've had major abdominal surgery. They need to get up, get out of bed. They need to ambulate, cough, deep breathe, and you're not doing it unless you're pain medicated. Make sure your child is also medicated because some kids will just try to do it just because they're trying to please you. So make sure they're very comfortable. Just like when you want them to breathe, I've done bubbles, I've done spitballs, I've done all sorts of crazy things to promote good pulmonary health, but after they've been medicated for pain. Those pinwheels are great too. I would tell parents to bring them in. Now, we talked about that bladder exstrophy, right? Bladder outside the body. Well, here is, some of the insides. It could be the stomach, could be the liver, could be some organ. It's just a bunch of insides that shouldn't be. Now, again, what is our concern? These children, we usually will see this in an ultrasound. So usually they're done in a C-section and they're planned for, okay? At birth, this big inside of the body, intestines, liver, intestines, whatever it is, it's in a sac. It always comes out in a sac. Make sure that we cover it with a wet, sterile, normal saline dressing. Again, preventing infection, keeping it moist, okay? These children will be on their backs. You're not going to have them on their tummies. They've got this protrusion, right? So they need to be on a monitor. Absolutely. They need to be in a warmer. We need to monitor what's going on out there. You're not going to wrap them up in a blanket because, again, you need to see what's going on there. And again, antibiotics, IV fluids. Now, intussusception. The lowest I've ever seen this in age get it was a 5-month-old. It's really hard to predict in those young kids, but it's usually that 2, 3-year-old kid all of a sudden comes in screaming and yelling, legs are going in and out, and they have severe abdominal pain. And it happened all of a sudden. What happens? The intestines sucked up into the other one, and now they're swelling and all those nerve endings are creating severe pain. What the one symptoms you see besides sudden abdominal pain is you might see in their diaper or their underwear this little currant jelly looking stool. So Hirschsprung's is those ribbon stools. Intussusception is currant jelly stools with maybe a little blood streak in it. We'll do an ultrasound if we can catch it. If it most of the time they come out by themselves, and we'll send them home on a high fiber diet just to keep their stools moving. But sometimes we have to do surgery on them. But that I've only seen once. A meckel diverticulum. I call this a skin tab in the small intestines. And inside that little skin tab is this huge blood vessel, and it rips. And now you have what we call painless rectal bleeding, bright red blood coming out of the rectum. You're going to see it that way. And it's a surgical treatment, and it's treatable very easily. IBS, mouth to anus, something's going on. There's an inflammation. Is it a colitis or is it a Crohn's? Is it sections or is it the whole thing? In ulcerative colitis, you're going to see profuse diarrhea. Many times it's just steroids. Sometimes children get biologics in order to control the inflammation. And sometimes they need to go get pieces of their intestines taken out. Again, because of the problem with the bowel and the absorption, we need a really, really good diet with this one. Short bowel syndrome. Do you know what that means? It means for some reason we had to take out a huge portion of intestines. Now, gastroschisis is like your omphalocele. Okay, that's the same thing that's there. Now, necrotizing enterocolitis is something that happens with your young infants where maybe they had hypoxic episode at birth and their intestines isn't really ready to eat yet. And we feed these infants. And the food gets there, and the intestine says nope, and it sort of loses blood supply and dies, necrotizing. Symptoms would be an abdominal distension, and there's like ripples on the abdomen. So that's why we measure circumference, abdominal circumference, before we feed young little newborn intensive care babies. All right. Well, I had one girl, her name was Jessica. She was a triplet. She was a cardiac child. She was on her second stage surgery, and she had necrotizing enterocolitis. We were feeding her very slowly postoperatively, but her body didn't want it. We had to take her to surgery, and we removed 48 or 50 centimeters of small intestines, which is a lot of area that should be absorbing nutrition. So, what is our big thing with short bowel? Nutritional support. That child did have, like he has, a Broviac, hyperol and lipids at night. During the day, had the G tube, got G tube feedings, and she even ate some orally. Nutrition, because her body couldn't use it. There was no absorption. That small intestines was literally non existent. Hernias can be many different places. I mean, I like the little belly button ones that you can squirt in and out, right? As long as they're soft, they're squishable, go in and out, don't have pain, you're fine. The problem is if that belly button, whether inguinal, whether it's umbilical, it is, if you can't push it, it's hard, it's painful, it's strangulated, it's incarcerated, it needs to be untwisted, it needs surgery now. Now, have you ever heard of an infant born without an anus? It's called an imperforated anus. Why do you think we do a rectal temp at birth? We're making sure, right? We know there's all sorts of fistulas, and we nurses are the one who finds them. We're seeing stool coming out of vaginas. That's the one that I always remember. Or urine. It's like, wait, this is coming from the wrong place. And that basically will take the physician to go and look for where it's coming from. Kids, everything in their mouth. They put everything from medications to their medicines and vitamins to biting on windowsills and chewing on, household things. There's so much with it. I think that in my career, with 911 and working with, poison control, the biggest thing they like to swallow is their vitamins. They just love them and they'll eat them, eat them, eat them. And something, it doesn't hurt because what you don't need, you just urinate out. It's when they get into the aspirin and ibuprofen and grandma's medicines, et cetera, et cetera. So vomiting, what are we going to do for vomiting? Well, you can't eat if you're profusely vomiting. So dehydration, what did I say before? We're going to draw a profile. We want to see electrolytes. Where are they? And we're going to be giving IV bolus. Remember, no dextrose, no potassium with a bolus. That comes afterwards. Reflux. This is when the food goes up and down. It could be small infants, and these children, it's a baby. They have reflux. They're gonna arch in your arms, and you're gonna go, "Ooh, this baby is reflux." How do we prevent that? Well, number one, don't overfeed them. Make sure they're burped well and they're sitting after feeds. If all of that stuff doesn't work, thicken the feeds, whether it's breast milk or whether it is formula, a little bit of rice cereal. Now, even for newborns, they're not going to get nutrition from rice cereal, but they're keeping the milk down, so they're getting nutrition that they would have puked up. So that's why we do that. Older children with reflux, what are we going to see? Well, older children, they're refluxing. That means food's going up their esophagus. Little pieces are going into their lungs. They're having mini refluxes, aspiration pneumonias, and they're coughing, complaining of burning, in their chest area. Sometimes when it gets to be really bad reflux, no medication, no treatment you do works, they're going to do something called a Nissan fundoplication. If you've ever seen a gastrostomy tube, they usually, when they do that, do a Nissan fundoplication. It prevents that child from vomiting. It prevents food from going up the esophagus. It's a surgical procedure. Now, about 7 weeks old, I would say. They say somewhere between 7 days and 3 months, something like that. You're going to see a child, infant, brand new, come in and mommy's going to complain, my baby's vomiting and vomiting. Well, my first question, is it dribbling down the front or is it projectile across the room? Now, I've seen a lot of these. They're very common. And what happens is the pyloric sphincter gets so tight. That's where the end of the stomach empties into the small intestines. It's so tight, milk can't get down. So the stomach fills up, they eat, they're fine, and all of a sudden, this projectile vomiting, point that kid at a garbage can 10 feet away, and they'll hit it. That's how far the vomit will go. Projectile. Now, if the parent tells me they're projectile vomiting, I'm going to take my hand and put it right underneath their xiphoid process. And I'm going to feel it says an olive or a marble. There's a hard round something in that right below the xiphoid process in the abdomen. And that's the pyloric sphincter that's really hypertrophic. So, how do we treat this? Well, as soon as we know it's vomiting across the room projectile, nothing more to eat or drink for that infant. They're going to get the ultrasound. We're going to determine, yes, that's what it is. We're going to start IV fluids, or we're going to get them to the OR. Postoperatively, once they wake up, very slowly, we'll start to feed them again. And we'll start with more on the clear liquid side and then increase it to regular diet. Cleft lip. I think it's one of the hardest things for parents to look at when they have a child with a cleft lip, because it's big upper gum is hanging out, and sometimes it's up into the nose. That lip, we're going to close that about 2 to 3 months old. Now, what are we going to do in the meantime and them eating? Can they suck? Not really. So this is a child who's going to need some really, really special bottles to help them eat. Where it's called a Haberman bottle. You can squirt a little bit and they're sucking, they still get that same feeling. Now, sometimes not only it's in the lip, it's the palate, that hard palate, the upper roof of the mouth. We're going to do that one about 6 to 12 months. We try to do it before they start to talk. Because if you ever known an older person that had cleft lip, cleft palate, and wasn't really repaired very well, they talk like this. They don't have that really distinct way of talking, and it's because of the structure. So we try to do that as quick as we can. That's the bottle that we would give to them. That whole top, when you turn over, fills with milk. As they suck, we push it. They're getting little bits of milk, and they really enjoy it. So that's pretty neat. Um, Breastfeeding can be very difficult. Breastfeeding is they have to suck, so sometimes mom has to squeeze it. Really takes a determined mother to do it. Remember, 2 to 3 months is when we close that lip. So it's going to be a while. And again, you're going to worry about growth. Are they getting all their nutrition? And then esophageal atresia, A is without. That means the esophagus does not connect to the stomach. And tracheal esophageal fistula is a connection between the trachea and the esophagus. That means if you eat, fluid goes down, goes across that fistula into the lungs, and you're gasping and choking and you're aspirating. Okay? That's what we usually see and how we diagnose it. So our goal with esophageal atresia, tracheal esophageal atresia, is to NPO. They can't eat. It's not getting to where it needs to go. These children will also be on antibiotics prophylactically, because if it's going in the stomach, there's no stomach, it's going to come up. And most of them have the fistula with it. It's going to go into the lungs. We are aspirating, aspirating. So they're going to be placed on antibiotics prophylactically. They're going to be NPO. Always have suction at the bedside in case they're gasping with so much mucus in their mouth they can't breathe. And of course, elevate the head of the bed. That's just the first thing always. A lot of stuff. Have you ever heard of half of this stuff? I know it's like crazy of these diagnoses that we have here. Who wants to win a cahoots today? It's an interesting one, and it does cover this again pretty well. I'm going to pop through it pretty quickly. It's like 50 some odd of them, so I don't want to keep you here forever. All right, let's go ahead and get going. We have a swag today, okay? Week 8, GIGU. All of the following are symptoms of dehydration in an infant. Dry, pale skin, loss of elasticity, tenting, weakness, lethargy, elevated heart rate, decreased blood pressure, decreased urine output, decreased sensorium, right? All of that. Big concept, dehydration. What is priority treatment for a child with dehydration due to profuse vomiting? A kid is vomiting. How are you going to treat it? Because remember, dehydration's bad. IV fluids with vomiting. If you try to give them something oral, it's not going to stay there. So, IV fluids, absolutely. What is the treatment for an infant with diarrhea lasting for 4 days? Well, a normal kid who comes in with diarrhea for 4 days, who's still alert and talking to you, we're just going to give them Pedialyte. Now, the kid comes in with 4 days of diarrhea, who's lethargic, elevated heart rate, signs of dehydration. That's a child that would get IV fluids. But remember, we still want to feed them. We still want to keep that stomach going. What acid base imbalance may you see with a child that's having profuse diarrhea? As I said, you're going to see acid-base questions from me. I remember one essay had 4 acid-base questions. Diarrhea. What is diarrhea? All those digestive enzymes, and they're all alkaline. We are losing it, losing it, losing it like crazy. So what is left? Acid, metabolic acidosis. All right, I'll tell you the other end. What if you're vomiting? What acid base imbalance? Well, the stomach is acid, right? You're vomiting acid, losing it all. What is left? Metabolic alkalosis, okay? A multi. In an infant that's not past meconium stool in the first 24 to 36 hours, what would you assess for? So we really don't look at electrolytes imbalance. It really doesn't, no stool does not reflect that. It's hypothyroidism, cystic fibrosis, and some sort of obstruction like Hirschsprung's. Deficiency of vitamin D causes. How do we replace the deficiency in vitamin D? Isn't it as easy as giving milk, right? Vitamin D. The kid's old enough. That's why we give breastfed babies vitamin D. It is called rickets. What is rickets all about? It's about bones and crooked bones. Scurvy is vitamin C. Oranges. A multi. What treatment can the nurse anticipate to a child unable to drink or eat anything with profuse vomiting and diarrhea? So if you're vomiting and diarrhea, what are you going to have to do for that child? And it's profuse vomiting and diarrhea. Well, again, that profuse diarrhea is telling me it's IV fluids. Absolutely. and of course, a metabolic profile. Now, are we going to feed that child something by mouth? Well, yes, we'll give an antiemetic like the adonstron, that Zofran. Wait a little bit and slowly introduce little pieces of maybe Pedialyte, Gatorade, one of those things to that child. But initial, first treatment, let's get that profile. Let's see where we stand with all our electrolytes. Let's give some IV fluids. A multi. What nursing management would you anticipate for a child with a ruptured appendix postoperatively? Remember what that appendix did? It burst and spewed all of these toxins inside the abdominal peritoneal cavity. Well, the kid post-op needs to be up out of bed, ambulating, coughing, deep breathing, so complete bed rest, no. NG tube suction, absolutely. Remember, those intestines are angry. We need to keep them empty. That's why we keep the NG tube to prevent stomach acid from getting there. IV antibiotics for the infection. And, we've closed a wound with two, what we call infected pieces of skin. The abdominal cavity was infected. So we need to watch it. I've seen it to hiss before. So making sure it doesn't open up. Passage of urine, usually at night in children who should have voluntary bladder control. I didn't go over that in class. It's just one of those answers. If you look at the others, you should be able to figure out which one's which. Epispadias, the urethra comes out on the top. Hypospadias is on the bottom. Vesicular reflux is the bladder going up to the ureters and refluxing. Enuresis is wet in the bed at night. Yes. Multi. What is Hirschsprung's disease? What's the other name for it I told you? And it's called a congenital aganglionic megacolon. Remember, aganglionics, no nerve cells. And that congenital absence of the cells, absolutely. There's no nerves in there. That's why it doesn't work. A multi. When teaching parents about Hirschsprung's disease, the nurse would include you have a little baby, not stooling, just found out baby has Hirschsprung's disease. What are you going to tell these parents? So Hirschsprung's is a bowel obstruction. It is something post-operatively. Of course, make sure that we've done this manipulative surgery, that they're moving their bowels the way they should. But it's a two-stage surgery, hopefully. We never treat anything with children with laxatives and enemas. That is an emergent one time. Like with that constipation child that hasn't stooled for 10 days, we're going to give one enema to get it moving. Besides that, no. What type of stools would an infant with Hirschsprung's disease have? So remember, it's this big outpatching and there's that little narrowing towards the anus. And sometimes a little bit of stool gets by. What would you see in that little tiny little? And it's called ribbon-shaped stools. Very good. This sort of squeezes out of there. What is a condition that occurs mainly in children when the intestines telescope into itself? Sucks in. Remember, sudden onset of abdominal pain. And that is called intussusception, okay? I don't go over volvulus. It's a little strangulation, embryonic thing. Strangulation I did. It's about the hernias where they twist. Paralytic ileus. That's something that happens post-op. And you do a lot of intestinal manipulation, like Wilms tumor. That could cause a paralytic ileus. A multi. A 2-month-old infant has GERD and has been treated by thickening formula. How do you know that it's working? So if this little 2-month-old's been spitting it up, and then you thicken the formula, how do you know that that worked good? Well, that infant's now not going to have regurgitation, right? And it's not going to be spit up. They're getting nutrition, so their weight's going to go up. That is the two things that you would see. How can you decrease the incidence of enterobiasis in children? What is enterobiasis? What a name, huh? So another name for this is pinworms. So remember, this is from children, their nails being long and dirt and eggs get underneath, and then they put their hands in their mouth. Keep their fingernails short. That's number one. Of course, hand washing, but nails is number important. So what are the signs and symptoms of enterobiasis? And that's intense rectal itching. Yes. Remember, it's Scotch taste tests. Get it. If they get the little tiny little pinworm there and get that to the doctor so he can see it. Gastroesophageal reflux disease. What's that? And that's just when the stomach and the esophagus and food just keeps going up. And remember, the big concern is the reflux and that aspiration pneumonia, especially in older children. You hear that coughing, that's usually telling you it is having many aspirations. What would the nurse be looking for with a patient that has Meckel diverticulum? Remember that's that little skin tab, I call it, with that big blood vessel in it in the small intestines. And what you'd see is basically painless rectal bleeding. Sometimes there's slight abdominal tenderness, but usually you just see blood. A 6-year-old child goes to the ER due to abdominal pain, fever, and vomiting for the last day. What assessment is priority? What do you need to know about that? The one of the things that I used to always tell my kids when I have that is show me where you hurt. If it's in the umbilicus area, that's more of gastroenteritis type thing. Right lower quadrant, that's telling you there is an appendix, and then we need to get that kid prepped, possibly for surgery. Okay. That's what that question was talking about. What would the nurse expect to see in an infant with biliary atresia? No connection between the liver and the common bile duct. There's no connection. So remember, the liver takes fat and breaks it down for our body to use. So clay color stools, abdominal distension because of all the fat. They can't absorb it. So then we would see all of that extra fat in there. What structure of the mouth can be impacted by cleft lip and palate? All of the above, right? I've seen one, I've seen two, I've seen one with a palate, I've seen two with a palate. and then I've seen them post done, and they can do a great job done by the proper surgeon. Don't even know barely it was done. Cleft lip repair is usually done when? Because we want to close that lip up as quick as we can. We do it about 2 to 3 months. The child a little bit bigger. It's easy to see the edges and approximate the lip up. But it is about 2 to 3 months before they do it. And when does the cleft palate repair typically done? Remember I told you the palate and closing it is really dependent on a child's speech, right? Without the palate closed, they cannot pronunciate words the way that they should. So that's usually done at 6 to 12 months. Esophageal atresia. What's that? Esophagus with an atresia. Esophagus without an opening. What is that? And that's the lack of opening between the esophagus and the stomach. A is without, remember that. What are the classic signs of esophageal atresia and tracheoesophageal fistula? What would you see? Because you don't always see this in infants, okay? We don't know it before they're born. I mean, just think about what we do as nurses. We get them out, we get their airway open, and then we try to get some sort of glucose in them, right? So we're giving them some liquids. When we give them the liquids, that cyanosis, choking, coughing, gagging, that is giving you that clue. Now, an olive-shaped mass, pyloric stenosis. Current jelly stools is intussusception. Those are things you need to remember. A multi-select. A neonate with suspected tracheoesophageal fistula, nursing care should include what? We have a connection between the trachea and the esophagus. What is our biggest concern? Well, we don't want stuff to go from the esophagus into the lungs, right? So, elevating the head of the bed in NPO, we were not going to feed these children, okay? And we're going to give IV fluids and we're going to give antibiotics because they are having mini aspirations, even on their own mucus, their own spit, they're swallowing it. So it is going into their lungs. That is basic care for TE fistulas. A 5-year-old child is complaining of epigastric pain and a persistent cough. What would you suspect? Epigastric pain, pain in the chest, and that cough, cough, cough. What is that? That is gastroesophageal reflux on your older child. How would we treat it? We'll diet and maybe start out with a little bit of Pepsid, right? Famotidine. What is ranitidine used for in a child with peptic ulcer disease? I mean, ranitidine was your Zantac, as I said. Now we're using Pepsis, famotidine, famotidine. And what that does, it stops all of that acid. So if they're having that gastroesophageal reflux, it will help the acid from burning up their esophagus, okay? And that with a change of diet, hopefully will stop the reflux. Signs and symptoms of hypertrophic pyloric stenosis. Remember, these are your very young kids. Usually the sweet spot's at 7 to 8 weeks old, believe it or not. That seems to be the age where they come in with this. And again, It's where that pyloric stenosis, that pyloric valve doesn't let milk go down into the intestines and it fills up the stomach, and all of a sudden you just vomit projectile. You're going to feel that olive or like a marble, a hard and round area right around, as I said, underneath that xiphoid process. They say the right upper quadrant, midline, somewhere around there. Signs and symptoms of hypertrophic pyloric stenosis. What's the big thing? Remember I say I get an infant in, I got one question. How is your child vomiting? Is it dribbling or is it across the room, right? The big thing with pyloric stenosis is projectile, and I am not exaggerating. It is quite impressive. Preoperative treatment of pyloric stenosis includes, so the kid can't eat, can they? No. They eat, they're going to vomit. Plus, we know they're going to go to surgery to stretch open that, do a myringotomy there, type of open up that pyloric valve there and to allow it to flow down. Remember, these are infants. NPO, start an IV, giving them their sugar, get them ready for the OR, and give mommy a hug because mommy's having a moment. What does the celiac disease affect? Remember, celiac disease is all to do with nutrition, has to do with gluten, right? So, where do we do all of our digestion in the body? And it is the small intestines. If you have celiac disease, what should you eliminate from your diet? Wheat, rye, barley, and oats. Those are the things that you see. And it's those breadings, it's, cookies, it's cake, it's bread, I mean, there's so many things that need to be eliminated. Rice is an alternative, and they're having more and more different sort of flours today that children can use. And I know a lot of parents are cooking that way. I work with a nurse whose son had celiac disease, and the father I worked with, the nurse, used to always, cook him or make sure he had that gluten-free whatever for whatever parties at the school. And he used to always make sure his son was involved with it. So you can make it normal as possible because I know what he looks like when he hurts. I took care of him. Priority nursing care of a child with a ruptured appendix post-operatively. So, post-op appendix care, what is priority? What is our biggest concern here? Infection. So this is the other one. Is it fluids or is it pain medicine? This is absolutely antibiotics first. Need to treat that infection. Yes, you're going to maintain the pain, but priority is the antibiotics. A multi. How can you assess the effectiveness of fluid replacement for a child with severe dehydration? Remember, fluid balance, adult children don't matter. How do you measure it the most effective way? Intake, output, daily weights. All right. Heart rate, blood pressure, capillary refill, urinary output. Excellent. All of these things are part of it. A multi. Vitamins that children with celiac disease are prone to lose are, remember, they don't absorb fat, right? So, what fat vitamins would these children not be able to absorb? This is the way you need to think about these sort of questions like, oh, I don't know. Well, celiac is about fat absorption. A, D, and K are all fat. Vitamin C is water soluble. Okay. What foods would you select for a child with celiac disease? No, wheat, rye, barley, or oat. Which one of those don't have any of that? So this kid can have bacon, eggs, fruits, dairy, all of that good stuff. So that's why that answer. Fish sticks has a coating. Macaroni and cheese is some sort of grain, right? So just remember those things when you look at that. Any breading? No. Phimosis, what's that? The funny part is I worked with a boss and she was my best friend actually. And she had a son, and I literally had to go help her with a bath every night because she could not pull down the foreskin of her own son. She made me do it. It's actually the foreskin is too tight. Yes, sometimes it's tight. You just got to pull it down again. Keep it clean. Decreases the incidence of urinary tract infections. What is a hydrocele? Hydrocelous fluid in the testes. An older patient complained of they might be incontinent and then a pain in the testicle, okay? Younger children could be the same thing. Infants, it'll go away. It just takes some time. Sometimes antibiotics, sometimes no. A hypospadias is. So remember, we have a hypospadias, we have an epispadias, extrophy of bladder, got all sorts of different names and stuff here. So a hypospadias is on the bottom side of the penis, okay? Epispadias is on the top. What is cryptorchidism? So cryptorchidism is when the testicles don't come down. That's why when you get your first visit to a pediatrician after you have your baby, they're going to check hips and then they're going to check a male for the testicles, making sure they're down, and they're going to document it. And it's important that as a parent, if we see they're not down, as a nurse, if they're not down, were they ever there before? If it's a later on visit, that makes a difference in the care of these children. Was it ever there before? Did we see that? Or is this a new thing that it's gone back up in? You suspect an infant has a cryptorchidism. How would you examine this infant? What's the best way to get the best examination, did I say? So if you have a room cold, those testicles go up and you're not going to feel anything. Nice warm room, the testicles, the scrotal sac will hang and you might be able to feel them. So it's better in a warm room, be more valid exam. A multi. How is hypospadias corrected? So they use the foreskin and then they put that catheter stent in postoperatively. Remember, this is general anesthesia. They take the penis and cut the whole bottom and fillet it open. You do not want that done under local anesthesia, okay? It is general anesthesia, and it's quite a big surgery. What is bladder exstrophy? So bladder exstrophy is that midline didn't close, the bladder was left open there, and this is something that happens during, the embryonic formation of the body. Again, our goal is to keep the skin integrity and keep it as sterile as we can until we can get it put back in. We're still going to measure the urine in the diaper. It's still going to come out the same way. The bladder's just in a different place. What is the priority nursing care for an infant with bladder exstrophy? This whole thing is all about tissue integrity and then, keeping it good and moist and also infection free. What are the clinical manifestations of nephrotic syndrome? Remember, this has nothing to do with kidney failure, right? And literally, when they go into this, we literally treat them with steroids. It's the way that it's being done. We're going to see the protein in this child. It's being just spewed out in the urine. We're going to see swelling. We're going to see low albumin in the blood. Hypoalbuminemia or low serum albumin is the same thing here. Children with nephrotic syndrome are often given what medications for fluid overload? Now, remember, nephrotic syndrome, this is a huge concept. A lot of the fluid's gone interstitial. You need to pull it back into the blood vessel, and then we need to get rid of it. How do you pull that fluid back? You're going to replace the protein, right? And that protein is albumin. So the way we treat this, get rid of all this extra fluid or, all of the fluid, the eyeballs and the fluid around them all swollen. What are we going to do? We're going to give them albumin, which is protein. We give it, there's a liquid that we give in an IV. And then once we give that albumin, we can pull out some of the fluid interstitial, give that furosemide Lasix, it pushes the fluid out and they can get rid of all the extra fluid. What is used to treat nephrotic syndrome in children? And it's prednisone. It's not an infection. We don't just monitor them. We stop the inflammation, we give prednisone, and it does help. A child is admitted with acute glomerulonephritis. What recent illness could validate this finding? So remember, rheumatic fever, acute glomerulonephritis are both caused by strep B. It is a recent pharyngitis. That is something you should remember. What is the priority nursing care of a child with nephrotic syndrome? What do we need to monitor? Priority nursing care. Remember, nephrotic syndrome, it's all about fluid retention or losing too much. It doesn't matter. Daily weights, intake, output. Okay? We're going to decrease salt. Blood sugars have nothing to do with it. And ambulating, well, maybe. Why is erythropoietin used in chronic kidney failure? What does erythropoietin do? And we know this is part of the kidney's function, isn't it? And with kidney failure, do we have enough? Not all the time. Has all to do with production of red blood cells. That's why hemoglobin hematocrits are so low with anybody with kidney failure. A multi. Children with chronic kidney disease can have renal osteodystrophy. What can this do to the child? What is osteodystrophy? Break the word down, and that's the answer. Osteo bone dystrophy not done right. Skeletal abnormalities is exactly what it is. Also, there's a problem with too much calcium in there, and the body does not like too much calcium, all right? So that is the reason you'll have these bone problems. They're not going to grow the way they should because they're crooked and because your calciums are too high. A diagnostic finding of acute glomerulonephritis may be, I mentioned this with rheumatic fever. It's one of the tests you can do in order to determine, did this child have this? And it's that ASO titer, anti-streptolysin. And that can say, oh, yes, you did have it. It's positive. Okay, we have confirmed acute glomerulonephritis due to a strep infection. Let's treat the strep. Which complication of peritoneal dialysis is most important? Well, what's the one thing you don't want to happen if you're using an abdominal cavity for dialysis? What's your biggest concern? And that's peritonitis, okay? It's nothing to do with an aorta. There's no tube going there. It's in the peritoneal cavity. It's not touching the aorta. It's all about keeping that kidney, which is your peritoneal cavity, working and functioning so we can remove toxins from the body. What clinical assessment is most important to report with a child diagnosed with an acute kidney trauma? You know, I had a child, it was 9 or 11, somewhere around there, playing, tag with kids, ran around a corner, going backwards, and hit a hitch on a trailer right about the level of the kidney. Came into the ER, huge ecchymotic area on the back of his back, right at the kidney area. Sent him in a high level alert. They did electrolytes. His potassium was 7.6. He had a fractured kidney. So kidney trauma, biggest thing to worry about, potassium. Kidney, potassium, makes sense, doesn't it? And all we did was rest that child. He did well. What would you do if the fluid draining from the peritoneal dialysis has changed color and is now cloudy? So I've changed color. I'm cloudy. This is my only place for a kidney to work. I'm calling the doctor now because I'm getting the order for that antibiotic, and that will be my next priority. Give an antibiotic. It's changed color. It's cloudy. Something's wrong. It could be an infection. We don't need to think about it. We need to be safe, not sorry. A multi. What should the nurse anticipate for a child who just had a renal biopsy? Post-op care. So we've stuck a needle into the kidney and got a piece of it to look at it. What's our concern? Well, we're worried about the dressing and leakage, abdominal distension. This child will be on bed rest for 24 hours. Of course, you stuck a needle in a kidney. You're going to be monitoring is the kidneys working and taking output, and of course, watching that dressing. Very good. Last question. What would the nurse provide to an infant that cannot eat normally? Let's say you have that child who's a tracheoesophageal fistula. That kid cannot eat. What do you need to do to provide what they need for growth and development? And then I'll say, how does an infant soothe themselves that can't eat? What do you need to do? And it's that pacifier. Very big concept here. The child cannot eat. Provide them something they can soothe themselves with. That soother, as my husband says, or that non-nutritive sucking or pacifier. That keeps them calm and take care of them. Well, look at swag. And Faith. Good job, Faith. Number 1, Tia. Good job, Tia. Number 4, Cheryl, Justin. So I'm telling you, this is like one of those crazy type of weeks, things that you've never seen or heard of, different, than your med surge and adults. So remember, next week we're going to be starting exam 3 reviews again. If you want, you can always go to my YouTube channel and start the reviews already because I have last quarters there for you if you want to do that. Anybody who wants to meet with me before exam 3, what I suggest, please look at the reviews first. Come to me and I'll quiz you. And you can ask me questions that I don't understand or you don't understand that I can help you to understand, okay? So whatever you need to help you through this, I'm here. You just have to ask me. Thank you, guys. Have a great week.
Thank you. Have a good week.
You too.